colleagues, ladies and gentlemen, first of all, I would like to thank the organizers for this kind invitation. Jonathan asked me to expand on the French presidential election, but for the sake of time, I would advise to keep the questions after this session. This is my disclosure slide. And these are the learning objectives of this presentation. So more than 400 million people have diabetes mellitus worldwide, and probably 100 or 150 million have heart failure. So it's a very important clinical question to examine the relationship between these two conditions. And the first question I would like to raise is, what is the prevalence of diabetes mellitus when we are looking at heart failure populations? And the answer is high. This slide shows to you 3 recently published trials in chronic heart failure with reduced ejection fraction. And you can see that they are remarkably consistent, showing that approximately 1 patient in 3 has diabetes mellitus. And importantly, this holds true not only for reduced ejection fraction, but also for patients with preserved ejection fraction. This is a similar kind of presentation, trials performed in FPEF, and you can see that here again, the prevalence of diabetes mellitus is around 30%. What about acute heart failure? This is a summary of 8 recent acute heart failure registries across the globe. And you can see that the prevalence of diabetes mellitus here again is very high, particularly in the Middle East. You have one registry from Saudi Arabia where you can see that 2/3 of the patients were reported to have diabetes mellitus. So indeed, many of our patients with heart failure have diabetes mellitus. The other way around now, what is the incidence of heart failure in populations with diabetes mellitus? It has been largely overlooked. The first paper that I'm quoting here shows that the incidence of heart failure in diabetic patients is more than 2-fold increase compared to non-diabetic patients, and that approximately 30% of patients who have diabetes mellitus have undiagnosed heart failure. This is shown in a different manner. This is data coming from the large international REACH registry with patients with established coronary artery disease or high cardiovascular risk. If you look at the left-hand panel, patients with diabetes have the gray columns, without diabetes, the black columns, and you can see that whatever the subcategory of patients enrolled in this trial, the risk of incident heart failure hospitalization is increased by at least 30%. So, incidence of heart failure in diabetes mellitus is very high. What is the impact of the combination of the two conditions on outcomes? This is the acute heart failure ESC registry. People with diabetes are in blue, without diabetes in red. And you can observe that both in-hospital mortality, 1-year all-cause mortality, cardiac mortality, 1-year heart failure rehospitalizations are significantly increased in people with diabetes mellitus. And indeed, in this large population of 7,000 patients, they did a modeling analysis, and both for in-hospital mortality and for 1-year mortality, diabetes mellitus was one of the strongest predictors of outcome. This is a diabetic trial, ADVANCE, and we are looking here at the standard treatment arm. And you can see here again that heart failure events, the second column from the left, were more common than coronary events, unlike what we currently believe. And finally, this is a large MEDICARE population of more than 150,000 diabetic patients. You can see that those patients who have both diabetes mellitus and heart failure had a risk of dying which was increased by 10-fold compared to those without heart failure. Are there specificities in the management of diabetes mellitus in patients who have both diabetes and heart failure? Yes, there are. And the first point I would like to highlight is that the best way to avoid heart failure in a diabetic patient is to ensure a proper glycemic control. This is a large meta-analysis pulling nearly 180,000 patients, and you can see that the risk of incident heart failure hospitalization is increased by 20% for each 1 point increase in hemoglobin A1c. What do we know about old anti-diabetic medications? Metformin has a bad reputation amongst cardiologists, mainly because in the old recommendations, it was contraindicated in case of heart failure due to the risk of lactic acidosis. However, when you look at observational studies, this is not really the case. These are again data from the REACH registry where 20,000 people had diabetes mellitus, and you can observe that those patients who had both diabetes and heart failure tended to have a lower mortality than those without heart failure. So this is not demonstrated. The contrary is true for sulfonyl ureas, and there are many observational studies which suggest that sulfonyl ureas can are prone to develop heart failure in diabetic patients. This is a large registry coming from the UK, nearly 100,000 patients. The reference is metformin, and you can observe that those patients who were treated by first generation, in particular sulfonyl ureas, were at higher risk of incident heart failure. TZDs are definitely contraindicated in case of overt heart failure or severely depressed ejection fraction. Why? Because this class upregulates a channel in the kidneys which promotes sodium and water retention. This is a meta-analysis of trials performed with both rosiglitazone and pioglitazone, and you can see that both drugs were associated with a significant increase in the risk of heart failure. And we were able to show in the rosiglitazone trial record that those people who are more prone to develop heart failure are elderly, have compromised renal function, or have hypertension. Insulin has also a bad reputation amongst cardiologists because of the risk of hypoglycemia and the consequent rise in sympathetic tone and potential arrhythmias. However, when one looks at observational studies, there is not such a demonstration that insulin is associated with the increased risk of heart failure or all-cause mortality. And here we have one clinical trial, which is the ORIGIN trial, which compared insulin glargine to conventional therapy. And you can observe that in this randomized trial, there was no increase in the risk of heart failure hospitalization in patients who were treated by insulin. The publication of the SAVOR TIMI 53 trial raised a lot of concern regarding the heart failure risk for DPP4 inhibitors. Why? Because as shown on this slide, there was a substantial increase in the risk of heart failure hospitalizations in patients treated by saxagliptin. And there was no real plausible biological explanation, but this raised concern. The relief came from the TECOS trial, which was published 1 year later using sitagliptin, and as you can see here, there was no increase in the risk of heart failure hospitalizations in patients who were treated by this other DPP4 inhibitor. So at this point, we don't know if the results of SAVOR TIMI 53 are the play of chance or if it's specifically related to saxagliptin. GLP-1 analogs. You may be aware of this very large outcome trial performed in diabetic patients at very high cardiovascular risk, which was positive using the long-acting GLP-1 analog liraglutide. Heart failure hospitalizations were non-significantly reduced by 14%. So far, so good. However, I think that we must put a piece of caution for diabetic patients who have overt heart failure or reduced ejection fraction. Why? Because this trial, which was performed in patients with acutely decompensated heart failure with or without diabetes, suggests a strong negative signal in patients treated by liraglutide for those who had diabetes mellitus. And this is further outlined by this other study which was performed in Europe in chronic heart failure Here again, patients were either diabetic or non-diabetic, and you can see that the number of serious cardiovascular events was significantly increased in patients treated by liraglutide. Why? Because this drug induced in this trial an increase of 6 beats per minute in heart rate, and we know that increased heart rate may be detrimental. So I would suggest at this point to avoid this kind of anti-diabetic medications in diabetic patients treated with overt heart failure. Finally, sodium glucose cotransporter inhibitors. In most of the glucose which goes through the nephrons is reabsorbed in the proximal tubule by a cotransporter which is called the sodium cotransporter system. And the beauty of this system is that it not only reabsorbs glucose but also sodium. So if you block this cotransporter, you will induce glycosuria. This is how it works in diabetes, but also natriuresis. And there was a big trial published last year, which is EMPA-REG outcome, which used that kind of inhibitor, namely empagliflozin. And one of the striking results of EMPA-REG outcome was a very significant reduction in the rate of heart failure hospitalizations with both drugs tested in this trial. And this has raised a number of hypotheses, and at least 3 clinical trials will be performed in patients with diabetes and heart failure. And I think SGLT inhibition raises several important questions. One is the natriuretic effect, which is transient, is the only or the principal mechanism for benefit. 2, do SGLT inhibitors work in patients without diabetes and only heart failure? 3, if so, do SGLT inhibitors work both in FREF and in FPEF? And finally, are selective SGLT2 inhibitors, which is the main cotransporter, better than mixed SGLT1 and 2 inhibitors? We'll learn more from the ongoing or forthcoming trials. A few words to finish with on the heart failure management in patients with diabetes mellitus. In a nutshell, there is no difference compared to patients without diabetes. Meta-analysis of beta blockers, ACE inhibitors, studies with eplerenone, ivabradine show that these patients react in the same manner whether they are diabetic or non-diabetic. And this is true also when you look at sacubitril valsartan. This is a study which shows that grossly the effect of sacubitril valsartan was similar, although of a lower magnitude, in patients who had diabetes mellitus compared to those without diabetes mellitus. There is, however, one point which I would like to highlight. Diabetic patients with heart failure are at higher risk of hyperkalemia and renal dysfunction than those without diabetes. This is a large series of UK patients with newly diagnosed heart failure, and you can see that the presence of type 2 diabetes was associated with a more than 50% increase in the risk of hyperkalemia when these patients were treated by renin-angiotensin system modulators. So in summary, diabetes mellitus is observed in up to 40% of patients with heart failure. Conversely, heart failure is a frequent outcome in diabetes mellitus. The combination of diabetes and heart failure is associated with poor outcomes. There is no specificity for the management of heart failure in the presence of diabetes mellitus, but the risk of worsening renal function and hyperkalemia is significantly increased. And finally, some anti-diabetic medications are either contraindicated or should be used with caution when both conditions are present. This is true for glitazons, probably for saxagliptin, and for liraglutide. I thank you for your attention.